All right, so why self-management? Why is it important? Well, as we know, it improves outcomes in chronic diseases, and it is weaved into your PCMH. And I listed all of the PCMH standards that it is part of, and I highlighted where they mention it. Some of these are core and others are credit. So you have that to play with, but still it is a very important part of this recognition, as well as it is to do your diabetes chronic disease management. And here today we are very grateful for Mike. Mike is a consultant for the Center for Collaboration, Motivation, and Innovation. He has 25 years of experience and over 200 improvement efforts under his belt. He also has a quality improvement design, measurement, and practice coaching experience. And on top of that, that's how I found him, was online, because he was part of the development of the chronic care model. He was part of the team that created it at the, how do you say that, McColl Institute of Seattle. So we're very grateful for him to be here. He's doing this pro bono, and we really, really appreciate his time in putting together this presentation and for sharing his knowledge with us. And I would like to invite you all to be part of this. If you have any questions, feel free to unmute yourself, pause him, and ask him a quick question or whatever you think, because this is supposed to be an interactive meeting. So I just want you guys to get the most out of it. And with that, I will hand off the presentation to Mike. I'm going to give you the remote. 1 second here. Are you in control?
I don't think so. Oh, it says I can control your screen.
Yes. So can you control do you press the arrows so you can go from one slide to another?
No, it's not doing anything.
How about there? There?
Oh.
There we go. You got it.
Do I? Oh, I see. There's a bit of a delay. Okay.
Yeah.
Great. Okay. Well, welcome everyone, and thanks for this opportunity to talk to you about self-management support. As Grace mentioned, some of the work that we've been doing over the last 25 years in primary care has been to use the chronic care model. Let's see if I don't know if I'm using the wrong key, Grace, or...
Is it the arrows? You need to use the arrows. There, it's going. I think it's in a delay.
Okay. You know, okay, we'll work with it. I have a number of slides that will transition, so the delay may cause us some trouble.
Do you want me to control it then, Mike?
It might be better for you because it seems to be working better for you.
Okay. Okay.
Okay. Oh, good. So as Grace mentioned, we developed the chronic care model over 25 years ago. And one of the things that we've learned over the course of the last 25 years is that many teams are very good at implementing the chronic care model and improving their care for patients with chronic illness. But one area that they really do struggle with is this notion of self-management support. And how do we actually deliver that to patients in a way that can be accomplished in the relatively short time that you have in primary care. And what we've heard over the years is that people need a more concrete, structured approach to self-management support than what has been given in the literature in previous years. So if we can go to the next slide, what I'm going to do is talk to you today not only about the definitions of self-management support, but show you a tool that has proven to be very useful in doing goal setting and action planning with patients to help them with behavior change around their chronic illness and other self-management behaviors. And then I'm going to talk a bit about how you integrate those into primary care setting. So let's go to the next slide. When we talk about self-management support, there are all sorts of definitions out there. Or when we talk about self-management, patient self-management. I like to use this particular one because it's very straightforward. It's the things that all of us do on a day-to-day basis to improve your health and well-being. And so I've put down there that self-management is inevitable because whether your patients are managing well or not, they're managing no matter what. So they're doing it all the time. The key here is to get them self-managing in a way that improves their health outcomes and improves their sense of well-being. It's also, there are three major areas when we talk about patient self-management that the patient must address, and that's medical management, role management, and emotional management. And if we go to the next slide, I'll just give you examples of that. You can just start hitting the keys and adding them in there, Grace. So we're talking about medication management, treatment plan management, self-monitoring that patients have to do around certain conditions, managing their weight, managing their exercise, managing their diet. That's all the medical management piece that patients are involved in when they're doing their own self-management. When we talk about role management on the next slide, and again, we're looking at how you manage your chronic illness when you're at work, when you're at home, when you're volunteering, how you work with your family. These are all role management pieces that patient self-management is part of what you have to do. So clearly, if you're very, very sick, managing your work role can be very difficult. And then finally, there's emotional management. And this is probably the area that patients are most concerned about. If you talk to patients, what is it you are most worried about with your diabetes care? Unfortunately, they're not going to say my hemoglobin A1Cs, my cholesterol, and my blood pressure. They're going to say, how can I make my life the way it used to be? How can I manage the emotional component so that this condition doesn't have such a great impact on me? So whether they're stressed out, whether they're isolated, alone, angry, or as the fellow on the left is with his hands sort of up to his sides there, he's ambivalent about his emotional management of his chronic condition. Let's go to the next slide. So that's patient self-management. So what is self-management support? That's your piece of the puzzle. And that's a systematic provision of education and supportive interventions by healthcare staff to increase patient skills and confidence in managing their health problems. I can't emphasize enough the word confidence here. What we're really talking about when we're delivering self-management support to patients is increasing self-efficacy. Many patients, there's a direct link between patients' confidence levels and their health outcomes. Patients with poor confidence in managing their care have poor outcomes. Patients who are very highly confident about managing their care have better outcomes. So confidence is really what you're trying to affect when you do patient self-management support with patients. And there's one more definition here by Tom Bodenheimer. I first met Tom back in 2000. He was a primary care, I believe he was an internist at San Francisco Hospital. We talked to him about self-management support, and he said it's impossible to do. He said, there's no way you get this done in primary care. You guys are out of your minds. And he sort of challenged himself to try it out, and over the years, he's now become a real proponent of self-management support. And he added something new to the definition, and in the bottom part of this, I won't read it, but in the bottom part of it talks about a fundamental transformation of patient-caregiver relationship into a collaborative partnership. And that is really another key piece of what you're delivering with self-management support. You're increasing patient confidence in caring for themselves, and you're partnering with them. And the partnering is around partnering what they know about their lives and what it means to have a condition in their life, partner with your medical expertise. And when the two come together, then you have that fundamental transformation in the relationship. The patients are experts on their lives, you're experts on their chronic condition. Next slide. So if we look at, in the past, patient education has been the more traditional approach to what we deliver to patients. And we know that patient education is necessary, but it's not sufficient to produce behavior change. So I think many of you have probably experienced teaching education classes, and at the end of the class, everyone scores 100% on their knowledge test, and then you're frustrated by the fact that they go home and they don't act on anything that they've learned. So the self-management education piece of this is teaching the skills to help the patient solve problems that they identify as critical and integrating that patient education as necessary. Usually patient education is disease specific. Just so you know, for diabetes care, the average 1 hour visit with a diabetes educator, certified diabetes educator, has over 180 key messages that the patient needs to remember. And they typically remember 3. The first thing they heard, the last thing they heard, and something in between there that was relevant to them. So tailoring patient education to what the patient sees as relevant is very important because they're much more likely to remember it. With self-management education, the skills are generalizable across conditions, so they're not disease specific. And then, as I mentioned before, the faulty mistake that patient education assumes is that knowledge will create behavior change, but we know that confidence yields better outcomes and results in behavior change. In patient education, the goal is often compliance, and here with self-management support, the goal is to increase self-efficacy. And then critically, and this is how it impacts you in terms of your busy days, is in patient education, the teachers are usually you because they're disease specific and it requires a clinical background. But with self-management support education, the teachers can be you or they can be peers. They can be lay people, depending on what you're trying to accomplish. So what I've seen in many practices is using community health workers, volunteers to do goal setting and action planning and self-management support with patients. Let me just stop there because we're gonna move on to a specific tool. Any questions at this point? Allows me to get a sip of coffee too. Okay, I'll be stopping periodically through and asking if there are questions. So please chime in. Okay, Grace, let's go to the next slide. So there are lots of different self-management support tools. There's action-oriented patient education where patients actually do exercises and tasks during the education sessions. There's patient-centered goal setting and action planning, which I'm going to talk about under that concept of brief action planning. And there's also motivational interviewing. They're not all mutually exclusive. They tend to overlap with each other. And they're tools that are useful at different times, depending on where the patient's confidence level is and what they need to know about their chronic condition. But given our limited time today, I'm going to focus solely on brief action planning. And we'll go to the next slide. So what is brief action planning? It's a highly structured algorithmic process that allows you to go through and set a goal, a behavioral goal with the patient, and an action plan or an initial small step to achieving that goal. It's person-centered. That is, it's focused on what the patient thinks is important. And I need to add at this point that your agenda with the patient is, it doesn't mean that that's not important. You may be looking at a patient that you think, that you've got diabetes, your hemoglobin A1Cs are up over 9, you're a cigarette smoker, your blood pressure's high, I want you to quit smoking. But if the patient isn't there, if the patient isn't ready to quit smoking, no matter how much you hammer on them, they will not quit smoking. So identifying what the patient thinks is important is a first good step to build success for them so that they will become more confident at managing their own health. And we'll come back to that. It's a stepped care process. There's not one size fits all when it comes to self-management support, and brief action planning can be tailored to the patient's needs. And it's evidence-informed. And I say informed because it doesn't have Class A evidence yet, very little Class A evidence of randomized controlled trials, but there are no shortage of studies that show that patients that set behavioral goals and achieve those goals increase their confidence and have better health outcomes. It's also important to know that self-management support is based on and includes the principles and practice of motivational interviewing. And in the next slide here, the 4 key notions of the spirit of motivational interviewing are compassion, acceptance, partnership with the patient, and evocation, evoking from the patient what is important to them. Next slide. Now here's the algorithm that I mentioned. So it looks very, very busy, but once you get used to it, it's actually fairly straightforward. In the blue, you have 3 critical questions that you ask, and then in the yellow and the green are skills that you learn in order to deliver brief action planning to patients. I'm going to run through the algorithm briefly. It will give you a sense of how it works with the patient. But the important thing to keep in mind is that you need to stick to the algorithm. Quite often what happens is we get into a conversational tone with patients, and that can take you off the path of what you're trying to do with them and get you into long, involved conversations which may wander into other areas that for you in a 15-minute visit is not the best use of time. So staying true to the algorithm is and having fidelity to delivering brief action planning is what we're finding is really a critical piece of delivering this tool. So let's look at this first question. Next slide. The first question is there anything you would like to do for your health in the next week or 2? And we ask the question specifically that way. We make sure that it's a short period of time, because if you ask the question, what would you like to do for your health? You'll get answers like, I want to live long enough to see my grandchildren get married. And that's laudable and that's great, but you really can't build an action plan around that. So you want to keep it short period of time, something that they can get done in the next week or 2. Go to the next slide. You might get a variety of answers. They have an idea of something that they want to do. They're not sure and they need some help with an idea, or they might need to know what you mean. You mean, what do you mean? What do I want to do for my health? Or they may say, I don't want to do anything at this time. They're either healthy or they're not interested. So depending on the response you get, you can do a variety of things. If they have an idea, you run with that idea, and we'll come to what running with that idea means. If they're not sure, you can help them with a thing that's called a behavioral menu. So let's go to the next slide. And this is the first skill that you learn, is how do you offer a behavioral menu to people when they request or need it? And let's go to the next slide. What you don't want to do is show people a bunch of options that they can look at and then move them towards one, specifically maybe the one that you think is important. You really do want them to select a particular area that they think is important for them. So you say to them, you ask, would you like me to share some ideas that others have used or that might fit for your situation? Assuming the patient says yes, you can share 2 or 3 relevant, not too specific, varied ideas all at once. So you can maybe work on your sleep patterns, maybe work on reducing stress, maybe you want to eat healthier, but don't try to push them in one direction. Eventually an idea will prompt one of them their own. Again, you can say, just like some things you might try are working on your stress, better sleep, so on and so forth. And then you ask again, do any of these ideas work for you? And in many cases, a patient will generate an idea. They may pick one from the menu that you have, or they may generate their own, which is why you have blank circles and you can write in what it is they've decided. Let's go to the next slide. So when we look at where we are in the process here, we're in that yellow set of lines just under the first question. They have an idea, they're not sure. You've shown them a behavioral menu. For those that say not at this time, leave them alone. Don't try to convince them to set a goal. You can say, that's fine, it's okay with you. If it's okay with you, I'll check in with you next time. And most patients say yes. At some point or another, patients will want to do something either because they've had an acute exacerbation of their diabetes, you may get a test back that shows that they've got neuropathy, or they may start getting tingling in their feet, and now they really want to work on something. And I know you might be saying, well, it's kind of late at that point, but what we know from the research literature is that people that don't want to work on improving their health will not do it, no matter what you say. So if they say not at this time, say yourself some time and don't try to convince them otherwise. But let's say they have an idea or they picked one from the behavioral menu. The next question is, or the next skill that you need to learn is how to set a SMART behavioral plan with them. Let's go to the next slide. So skill 2, setting a SMART behavioral plan. SMART refers to doing something, getting them to be very specific about what it is they're going to do, something that can be measurable, something that's achievable, something that's relevant to their goal, and it's timed. So let me give you an example of a not so SMART goal or behavioral plan with the patient. Let's say the patient says, I want to increase exercise. That's their behavioral goal. A not so SMART plan would be the patient saying, well, I'm going to go out and start walking. And you say, great, terrific, we'll check back with you next visit and see how you're doing. Again, we know from the research literature, most of this coming from the mental health field, that without getting very specific with them, they probably won't do it, or they'll do it in a way that doesn't necessarily benefit them. So you ask the questions of, what is it you want to do specifically? Well, I guess I want to walk around the block. When would you like to do it? Oh, I hadn't thought about that. Well, I'll do it at lunchtime, since I'm working. Oh.
Sorry, Shauna was laughing outside.
I was trying to figure if I made a joke or not. Anyway, where would you like to do it? So they said, okay, well, I'll just walk around our building at work. How often, how long, how much? You get very specific with them, and what is their start date? All of that is very measurable. So they say, I'm going to do a block, I'm going to do it 3 times a week, I'm going to do it around my building. It should take me about 15 minutes, and I'm going to start next Monday. That's very achievable. It's relevant to their goal of increasing their exercise, and it's time. Now, many of you might be saying, okay, this person's walking one block 3 times a week. That's really not going to have a big impact on the amount of exercise they're getting, and probably no impact on their diabetes care in terms of A1Cs, blood pressure, cholesterol. But you're going to go ahead and say, that's fine, let's do this. Why would you do that? Why would you say okay to this particular SMART plan when it's really not going to have any clinical impact? I want someone to offer an answer. And while people are thinking of the answer, Jennifer, yes, we'll get you the algorithm as a reference. You can go to the website and download it from there.
I'll send this presentation out as well.
Yes. Yes, to help the person take ownership, absolutely. What's another reason?
Liz, over there at UW, do you guys have any comments around this? Teresa?
No.
Well, let me ask the question a little differently. How many of you have tried to do something to, yes, create accountability from the HealthWorks folks? Absolutely. How many of you tried to do some sort of self-management plan and not had success? And I'll assume that if we were in a room, you'd all raise your hands, because almost all of us have tried to do something, whether it's exercise more, lose weight, change our diet, quit smoking. We've all tried and we've all failed. But what happens when we succeed? When we succeed, we feel better about ourselves, and we are motivated to continue to do even more. So what's nice about this particular SMART goal for this patient is that while it may not have a clinical impact, if they succeed at it, it's going to improve their confidence and their self-efficacy. So again, remember what I'd said earlier. Your goal here is to increase patient confidence and self-efficacy that they can take care of themselves. Not that they complete a particular action plan or meet a particular goal. That's great when they do, but all of that is about increasing confidence. So, so then you might ask the question, well, what if the patient sets a totally unrealistic goal? So let's say you've got someone who is obese and they decide that they're going to start running. And they say, you know, you get very specific with them and they're going to run a mile every day next week. And you're sitting there thinking there's no way they're going to be able to do this. you can offer them, we'll come back to confidence in a minute, but there's a point in this process where you can offer them a chance to rethink that particular goal. But if they don't, if they want to stick to it and they aren't going to hurt themselves, you can let them go ahead, because they'll figure out very quickly that maybe they were a bit too ambitious. And we'll talk about how you can help them if they have failed at their action plan. So that's the SMART goal that you set with them. Let's go to the next slide. Next thing you want to do is elicit a commitment statement from them. So they've articulated the plan, the SMART goal, and what you do is elicit a final commitment statement. Now, you're going to find this hard to believe, but there's research that shows that if you get people to repeat what it is they're going to do and say, yes, I think I can do this, whether you shake their hand or get them to sign a piece of paper or whatever, it improves their potential for completing that action plan by 50%. So you want to elicit that commitment statement, and again, it's very, very straightforward. Just get them to repeat the plan and commit to it. Next slide.
Well, we had somebody use work
Yeah.
saying that it would create accountability. Is Jenna the answer from your question, that it creates accountability as well?
Yeah, the plan is theirs. It's not yours.
Mm-hmm.
So that's a really good point. And also from the Migrant Council, it's a good start. So yeah, it's the best way to start. Okay, so let's go back to the bigger algorithm. So we're now at the SMART behavioral plan, just below getting the idea of what it is they want. And we've elicited a commitment statement. Now we want to see how confident they are about carrying out their plan. So let's go to the next slide. And we'll go back one. Yeah. You need to ask this question specifically as it's written, because it is actually a validated question in terms of its, and a validated scale that it's on in terms of measuring confidence. So how confident or sure do you feel about carrying out your plan? And you get them to pick on a scale from 0 to 10. Anything that is below a 7, we know that they're not confident. Anything that is 7 or greater, they are confident. So if a patient says 7, 8, 9, or 10, you say terrific, and we get them on their way to do their self-management plan. Sorry, something just popped up on my screen there. If they're below a 7, we need to do some problem solving with them. So let's go to the next slide. And problem solving is not you solving the problem for them. A very simple way to help them do the problem solving is to say, you know, a 4 or a 5 is higher than 0. That's good. So you know that you can do some of this, and we know that people are more likely to complete a plan if it's 7 or higher. Any ideas about what would raise your confidence? And see what they have to say. They may say, yes, you know, I think running a mile a day is probably going to be too much because I haven't been running in 30 years. And at that point, you can say, okay, well, let's go back to the SMART plan and reassess the distance that you're going to run. If they say no, I don't have any idea about how to raise my confidence, again, you can show them the behavioral menu, and what they might actually do is choose a different behavioral goal. So this gets into socially desirable answers. If you're sitting with a patient that has diabetes, that is not well controlled, and they're not eating well, they're not exercising, and they may be smoking, their initial goal may be something that they think you want to hear. So they may pick smoking. But by the time you've gotten through the part of this BAP problem or this BAP process, they think there's no way I'm going to be able to quit smoking. So now's the chance to show them the behavioral menu again and say, is there something else you'd rather work on? And at that point, they know that they're the ones in control here. It's really this process when we say about, let's say, being patient-centered, is really about giving the control to the patient to do what they think is important. Again, I want to emphasize that your agenda for the behavioral issues that they need to address in your mind It doesn't say that that isn't important. It's just that you want to get success under their belt early so that down the road you can say you've done so well at this, this, and this. There is some issue that we'd like to tackle with you around blood glucose monitoring. We know you aren't doing it. We think it would be great. Would you be willing to set a goal around that? So your agenda will come in during this process. And in the vast majority of goals and action plans that are set, they're typically set around an activity that will have a clinical impact on patient's health. But they may choose something very wacky. I had one person choose to buy a puppy because he was so lonely. His wife had died 6 months prior, and he said to his doctor, I was working with this physician, I want to buy a puppy. The physician thought, oh my goodness, what am I going to do with this? But they actually went ahead and set a smart plan around when he's going to buy the puppy. They decided just to buy one puppy. And then when he followed up with the patient afterwards, the patient was very happy, loved the puppy. It addressed the loneliness issue for him. And he said, that, by the way, this patient had congestive heart failure along with his diabetes. And he said, but you know, when I take the puppy out for a walk, I get short of breath. Is there anything I can do with that or do for that? So you see how it comes back to a clinical issue, even though it started in a non-clinical issue. So in any case, show them the behavioral menu and see what it is they want to do, but make sure they solve the problem. If they ask you to solve it, again, give them some options and ask them to choose, because once again, they're going to choose the thing that is most relevant to them. Next slide. So back to the model now. We've asked how confident they are. Confidence is greater than 7, confidence is less than 7 on you do problem solving. Either way, you get to a point where their confidence is 7 or greater. And now what we need to do is make sure that we follow up with them. So you ask the question, would it be helpful to set up a check on how things are going with your plan? And let's go to the next slide. You ask them how they want a check being done. They may want a telephone call, they may want an email, they may have someone in their family that can check on it. So again, it doesn't have to be you doing the checkup. But what is important is if we don't follow up with patients and we say to, then we lose their trust very quickly. So we have to make sure that whatever plan you set up, you can follow through on so you don't lose patient trust. But where you can minimize the impact on you, given how busy your days are, make use of other alternatives. Again, email is a great alternative. If you have volunteers or CHWs working in your clinics, they can often do follow up with the patient. Next slide. When you're checking on progress, this is really about building confidence. So you're checking often with their action plans to decrease the frequency. Well, I didn't really write that very clearly. You're checking with them to make sure that they either were successful, or if they weren't successful, you can help solve that and also continue to build their confidence. So it needs to be a regular, fairly quick follow-up. One of the things I've seen that is not working very well for practices is they'll have a patient in for a diabetes check visit. At some point, they'll set a self-management goal, an action plan, and the next time they check back with the patient is 3 months later when they come back for their next check back visit. If the patient failed in their self-management action plan within a week of leaving the office, then they sit for 3 months feeling like they failed. So the follow-up needs to happen fairly quickly, especially for those patients that are struggling with their action plan. But it also builds a trusting relationship. Next slide. And go ahead, yeah. So when you're checking in, you just ask how did it go with your plan, and the 3 things are going to happen. They'll either complete it, at which point I'm starting on the left-hand side, complete it, you recognize their success and ask them what they'd like to do next, and you can start the process over again. They may have partial completion, so you recognize their partial completion and ask them what they want to do next to complete the whole process. Or they didn't carry out the plan, or it failed completely. reassure them that this is a common occurrence. You know, as I said before, we've all tried to do things that are difficult to do. We have lots of failures, and being reassured that failure is normal actually helps patients build more confidence. I just had a conversation with a good friend that's trying desperately to quit smoking. And he said, what happens if I fail? And I said, you probably will fail, but the research literature is very clear that the more you try, the more likely you are to succeed. And that really is about that confidence. And I said, so don't consider your failure, or don't be too hard on yourself if you fail, because it's a very common occurrence. Next slide. So that's basically the whole process. And what we found is that providers that learn BAP and become comfortable with it and explain the process to their patients basically can set behavioral goals and an action plan within 2 to 3 minutes. Now, clearly, the first couple of times you do it, it's going to take longer. But those that are seasoned in the process and keep to the process, keep to the algorithm, with patients that understand what it is you're trying to do, goal setting and action planning can be done within the confines of a busy primary care visit. Next slide. Okay, I'm just going to turn and check the time. I want to make sure I'm not talking too long. Okay, so some tips for using brief action planning. Let's look at the next slide. Avoid the expert trap. Remember, patients think that you have all the answers, or if they think they have all the answers, they still might run them by you to make sure that they're the right thing to do. So try not to jump in the middle of a patient struggling with an issue and tell them what to do. It's unfortunately, much of the training in academic medical or academic settings is that you are trained as the expert and you are trained to be directive. Now that is starting to change in a lot of medical curricula, but that has been the training in the past. So you might have to untrain yourself and learn to do what's on the next slide. And that is let the patient do most of the talking. Try to avoid interrupting them. Certainly if they've wandered off into a social conversation, you want to get them back on track, but really try to avoid telling them what to do, even if they ask you. So again, another example, my 90-year-old mother, shortly before she died, we was trying to teach her self-management support, and she said, my doctor tells me everything to do. So I talked to her doctor, and he said, actually, I get her to make all the decisions, but he did it in a roundabout way. What he would do is say, when she said, I can't get up and down my stairs anymore, tell me what to do. He said, well, Helen, I don't know how you live in your home. You're going to have to make that decision. I can give you some ideas. You can slide down the stairs on your bum, climb up on your hands and knees. Those times when you're feeling shaky, you can do some, have someone come in and do strength exercises with you. You can put in a chair lift that lifts you up the stairs. And she stopped and went, stair lift. That's what I want to do. So he said to me, by the way, now that you're asking, go put a stair lift in for your mother, which we did. Once we did it, and she was feeling very good about that, I said to her, you made the decision about the Stairmaster. And she said, no, I didn't. She said, my doctor told me to do it. But in actual fact, he did self-management support with her, and he got her to choose the thing that was most relevant for her. But he also maintained that relationship that many geriatric patients need, in which they believe the doctor is involved. So he was very good at doing it roundabout way. Avoid the assessment trap. In a lot of diabetes education visits, there's often lengthy assessments that are done, which is good information to know about the patient, but quite often what happens is you'll see information in the assessment and say, I know exactly what to do to fix that, and that sets you back into the directive mode of, I noticed you ticked off that you're having trouble with your diet. I'm going to send you to a registered nutritionist, a registered dietitian, and that may not be what the issue is for the patient. Maybe what they want is reduce stress. So use your assessment data to inquire about what is important for them, not to direct what you think their therapy should be. Next slide. So learning how to do this is a matter of practice and feedback. When we train people how to do brief action planning, we have an online module that people can complete, or we do face-to-face trainings. But after the trainings, we actually do practice and feedback calls with the people that we've trained. So they get on a call with 3 or 4 others that were part of the training, and they work with a standardized patient that steps them through scenarios, gets them to go through the algorithm, and then gives actually the colleagues as well as the standardized patient give feedback on how they're doing. And they typically just need to practice it a couple of times to get the process down. And then you just need to have the self-awareness to remind yourself to stay in the algorithm until it becomes unconsciously the way you do self-management support. Next slide. This is just a little background on what we've been doing. We've been training people since 2012. As of last year, we've trained over 2,000 people in brief action planning in the US and in Canada, and some in other countries like Kazakhstan. Long story there. Maybe someday I'll be able to tell you about it. What we find is that the vast majority of people that we train are nurses. We do train some physicians, but physicians, their expertise is in medical, delivery of medical expertise. It may not be the best use of their time, although some physicians very much like doing this work. But many physicians ask the nurse or someone else, one of the other allied health professionals in the practice, to do the goal setting and action planning with patients. But it's not just medical professionals. I mentioned earlier that peer and lay people can do it. We've had staff in women's transition houses using it, shelter workers, addiction and mental health workers, peer counselors in senior programs, and for pregnant women at risk. So lay people can do this work too. Certainly if the conversation wanders into a clinical issue, or if a lay person is doing it and the patient says, well, I need to know how to take my blood pressure medication properly, it may not be appropriate, wouldn't be appropriate for them to do a goal and action plan around that. But the vast majority of goals and action plans are not necessarily clinical. Next slide. An interesting study that was done looked at the impact of goal setting when BAP was combined with a family nutrition physical activities plan during well child visits. It was a controlled trial with 36 providers having support to use the FNPA screening, but only 19 of them were supported to use BAP. And on the next slide are the results of that. And what we found is that visits using brief action planning saw 72% resulted in an action plan, as opposed to 3.6 that did not use brief action planning. 56% of the lifestyle goals that were set were met. Providers were more likely to discuss and report issues like weight when combined with BAP. Provider satisfaction with the tool was high. And when BAP was used with patients, patients reported that they felt the visit was more focused on them. Next slide, please. As Grace mentioned earlier, delivering BAP fulfills that self-management support core competency in the care management section of the patient medical standards. But is BAP for everyone? And I think this is an important question. Let's look at the next slide. Part of the work that we've done at the Center for the Center for Collaboration, Motivation, and Innovation is develop a stepped care approach to self-management support, because depending on the patient's clinical care, mental health, they may need different tools at different times. So I'm not going to spend a lot of time on this model, but essentially the different layers, when you move from the bottom, it's the intensity of the self-management support intervention increases as you move up. So at the bottom level, we're really talking about helping patients navigate the healthcare system, understand what community resources are available. In the middle, you might have patients that need brief action planning, but all they really need is just they just need to be able to set goals and action plans and move forward with their confidence. At the orange level, you have people that are ambivalent about taking care of themselves or about increasing activity or improving diet. And they may need tools like motivational interviewing to help them understand the importance of the work that they are ambivalent about and move them off that ambivalence fence, hopefully in the direction of action. And then at the top, we have people that are very complex and probably have very serious mental health issues, either associated with their chronic illness or in addition, and they're going to need specialized care in specialized settings. Let's go to the next slide. For you, though, there's a very simple tool that we developed, and it hasn't been validated, but we did use it in a number of settings, and people found it helpful. For you, it's trying to get a sense of what does my patient actually need? Because the question we get from many primary care providers is, do I have to do this brief action plan with all my patients? And the answer is no. So if we look at this grid here, we have across the top clinical control and down the side self-confidence. What we know is that if you track clinical control, and clinical control can be your judgment. You may want to use hemoglobin A1Cs or the ABCs of diabetes, or just your gut about where the person's control is as to whether it's good or poor. Confidence, on the other hand, is very easy to measure. So depending on what their clinical control is and confidence, you have different things that you can deliver to them. So let's go to the next slide. Oh, sorry. In order to get confidence, you simply want to ask this question. And again, this is a validated question, so you want to ask it the way it's laid out here. How confident are you that you can manage your health in the next month? People are very good at projecting out how well they can do in the next month. They can't, once you get out beyond a month, the answers become unreliable. Again, 7 is the magic number. If they're 7 or above, they're pretty confident they can manage your health very well. If it's below, they're not that confident. So let's go back to the grid, next slide. So if you have patients that are in good clinical control with high self-confidence, you probably don't need to do any self-management support with them. It's just usual care to help them maintain the good clinical control that they have. If they've got poor clinical control, but they're very confident people, but they just can't seem to get that A1C below 7, you may want to ratchet up clinical care and medications, as well as doing brief action planning with them around diet and exercise or whatever they think is lacking in their behavior around managing their diabetes. For patients, this is down the yellow box down on the bottom there, who have good clinical control but low self-confidence. These folks are ripe for brief action planning, because remember, brief action planning isn't about getting a specific goal done, it's about building their confidence. So these folks are in a great position to be using brief action planning to help build their confidence. And then people with poor clinical control and low self-confidence, the red box, as I said, these partnership interview, motivational interviewing, or it may require specialized referrals to manage their conditions. What we find is that when teams track their panel of patients, or however you're set up, the patients that you're taking care of, we've seen that it varies, obviously varies depending on the complexity of your panel, but usually 50% or more of people don't need to be doing brief action planning. So that narrows down the population considerably. But remember that I can be in good clinical control one day and then poor the next. So I could move around in these boxes given any particular event that happens with me, an acute exacerbation. A heart attack would probably put me into the red box very quickly. So it's a good thing to do on a regular basis, not necessarily annually, but for those patients that are struggling with their diabetes, it's probably good to check in to see where their confidence is and link that with their clinical control. Next slide. So just summarizing, we talked about what self-management is and what self-management support is, and how doing self-management support is core to your PCMH designation. Brief action planning is one tool that is very patient-centered to assist patients with behavior change, and there are a variety of self-management support techniques. They should be tailored to the patient's clinical control and willingness to change. And I believe that's my last slide, except a thank you slide. Yes, great.
Thank you, Mike. I'd like to open up the floor to ask people, to share their experiences with self-management, if you've implemented it, what has worked, what hasn't. If you're looking for advice, I'd take advantage of this moment just because Mike has worked around with other federally qualified health centers. So it's not a for-profit organization, because that's one of the things our centers, really always consider is, where's the advice coming from? Do they really know what kind of population we're working with, to be realistic on what, the expectations are. So I'd like to see if anyone has questions. If you can't unmute yourself, you can always type it into the chat and we could read it off and address your needs, because this is your time and we still have a few more minutes before the time is over. So we have a comment.
Great, Jennifer. And if you go to our website, www.centercmi.ca, we're based in Canada and the United States. We're a virtual organization. You can download the brief action planning algorithm. There's a guide that goes along with it. If you feel you want more training, we can offer you training. We're pretty inexpensive because we are a not-for-profit. But the materials are all there, and there's white papers on brief action planning that you can download also. It's www.center, when we spell center the English way. So let me spell it out. CENTRECMI. So that's all one word, centercmi.ca, as in Canada.
And I'll get this presentation out to everyone and the links. And then also, Mike, do you have any videos where we can see this in action? It would be a nice thing to see as well.
Yeah, there are videos on the website that you can watch. Again, just motor around through it. I can't remember exactly where they are these days because we just redesigned our website and I haven't paid attention. But we do have videos of people going through the brief action planning process.
Perfect, thank you. UW centers, any questions or comments? Teresa? You guys are awfully quiet. They're not usually this quiet, Mike.
What about difficult patients? Is that an issue for many of you? And when I say difficult, I mean patients that can't follow their treatment regimen or medication regimen, patients that feel defeated.
Yep, so this is Jenna at HealthWorks. One of the things that we're working on rolling out right now is medication therapy with our pharmacists as part of our intro appointment to our care management. We're doing a huge focus on diabetic patients and A1Cs greater than 9. And so involved in that hour-plus initial appointment is dedicated time with a pharmacist to go through all of their medications and incorporate that into their care plan as well.
Mm-hmm. You made me think of an interesting situation where one nurse shared with me that she had been trying very hard to get her patient to take her medications, and she just would forget every day. And for a couple of months, the nurse would recommend a variety of things, gave her pill boxes, all sorts of things. Nothing worked. And then she tried doing goal setting and action planning around the medication management, which the patient agreed to do. She didn't force it on the patient. She said, yeah, I think it's really important. And asked the patient what they thought they would like to do. And she said, well, what would be ideal for me is to put my medications on my washing machine because I do laundry every single day. And then I would see them, but I assume I can't put my medications on my washing machine. So in one conversation, they solved the problem because quite often patients have assumptions that may not be realistic about what they can and can't do with their care. And so exploring that through brief action planning solved that problem for them very quickly. So what appears to you on the outside as a non-compliant patient, and I use that intentionally, is actually a patient that doesn't quite understand what they can and can't do with their treatment plan. Jennifer, yeah, you've got complex patients at the homeless clinic. And you use I'm just reading your message here. You use an integrated approach with pharmacists and a provider. This provides multiple points of contact with the patient on the same day. You say that you think goal setting would be a great application for these folks. I know that follow-up would be difficult with them, but I've worked with other folks in delivering care to homeless people, and what they typically do is they get the patient to either talk to their friend about it and get them to follow up, or they ask the person to check back in a few days just to follow up on their goal. Not necessarily another appointment, but just to follow up and let them know how they're doing. So depending on how you're set up, in this one particular clinic I worked in, the patient would come in and just leave a message that I'm struggling with this with my particular goal, or I managed to accomplish this. So follow-up wasn't didn't have the best continuity, but it was at least one way to approach it. I think and again, try not to talk too much and wait for questions, but with the extremely complex patients like this, there's so much that they have to do that they are often extremely overwhelmed. And so helping them recognize that, and that this is a process that is one step at a time. Nobody becomes an expert at anything overnight by doing it all at once. And so point out to them this is very normal. We'll take one step at a time, because you're really just trying to build their confidence. If there are severe mental health issues, brief action planning doesn't work that well if you're dealing with schizophrenia that is not controlled and other serious organic psychoses. You're probably not going to have a whole lot of luck with brief action planning unless they've got a caregiver with them. I'll stop talking at that point. Other questions? Any issues around how you might do this during the course of a day? Looks like we're coming up, is it 1 minute to the hour?
Yes.
Grace? My clock and my pension is so far away I can't see it.
It's okay. Is there anything else you guys would like to ask? Okay, that's it. Well, thank you, Mike. We appreciate you. This was
No,
great
thank you.
information, and I know that as they do this, or as they continue on evolving in their self-management program, that I think questions will come up, and so we know where to get a hold of you.
Yeah, I was going to say, please feel free to share my email, and you can contact me directly, and I'm happy to answer questions. If I don't know the answer, I'll find someone who does.
Okay, wonderful. Thank you again, everyone, for your time, and thank you, Mike, for doing this. We really appreciate you.
You bet. Have a wonderful spring.
All right, thank you. Bye-bye.
Bye-bye.
Sustainability of such centering models of care. So I think you will really enjoy our webinar today with a great overview and then frontline example. My colleague was on logistics and centering models of care. So I think you will really enjoy our webinar today with a great overview and then frontline examples of successful centering care.
Mike, I think you have to let go of it over on your end.
Yeah, I'm having trouble getting out of it.
Okay, I'll let you control. I think you have the remote control right now. So,
oh, okay.
There we go.
Okay.
And there we go.
And I'm